Thank you, both of you, for having me here. It's a pleasure to be here. I have no conflict of interest. The two most important days in life are the day you are born and the day you find out why. I was very lucky. My father told me why I was born, so I had no choice. Luckily, he put me into medicine, and I discovered surgery. And as Richard said, the passion remains in spite of my advanced age. Dr. Whitman, you don't need an intensivist in 95% of the open heart surgery. What you need is a surgeon to pay attention to detail. An operation well conducted, the patient can be extubated 1 or 2 hours later, regardless of how long, how complex was. And very, very few, except for the moribund patient that we bring to the operating room, those, yes, they need the expertise of a collaborative practice model that involves multiple specialists. But I'd like to submit to you that surgery is detail. I have done over 15,000 operations in my life. For 30 years, I was head of a group of 14 heart surgeons. And the anal ones, the patients move through the unit and through the hospital with very little problem. Are the more casual ones, or the less, say, gifted. Whatever it is, I don't know, Mark Twain was wrong about them. I don't think they found what they love to do. Heart surgery starts with the endogenous anesthetic, then have to make an incision in the chest. After 15,000 operations, I have done them all. And since my practice now, 1 patient 3 is a reoperation, you have to recourse to different incisions, including a transverse if they have no sternum anymore. If somebody removed the sternum before, think of a clamshell as an alternative. Those of you who want to start doing minimally invasive, start with a big incision. And every day we're going to operate through and make a centimeter shorter. Don't go try to see a pro making a 4 or 5 centimeter incision either there or here and get the job done. If you're not doing mitral valve repair or replacement to the right chest, make a long incision, 15, 20 centimeter. And then every day shorten the length. You're going to find that it works very well. Never, ever compromise the quality of the operation for this scar in the chest. This I learned the hard way. You can cannulate an artery anywhere. I would like to submit to you that there is no cannulation as safe as the right after the pericardial reflection in the mid portion of the aortic arch. If you measure embolism in the brain, if you see how many perioperative stroke you have, there is no cannulation that replaces this one here. You can do any place you like. You can do femoral. But you have to accept certain mortality and morbidity the moment you get away from this area. Even this area here that most of us do is not, at least in my hands, and of my fellows and my associates, is as safe as the level of the left carotid artery in the inner aspect of the arch. You can cannulate anything you like in the vein as well. Any place there is venous blood, you can put a cannula and suck the blood out with some 20, 30, or 40 of pressure. There's no cannulation that replaces the isolated superior vena cava and inferior vena cava cannula, because you can do any operation once you have a cannula on each cava. Now you're doing the operation. Unfortunately, this slide is not mine. I was a medical student when Dwight Magoon gave a talk on aortic valve replacement, and he said there is no perfect heart valve substitute. This was 1978, when he was president of the AHS. Unfortunately, 37 years later, this is still true. And that's why you have to try to repair whenever possible, but only if the repair is better than what we have in replacement. Judgment and experience plays a major role, which valves repair, which valve should replace. We are very lucky. I lived through an era or the imaging exploded. So it's by and large, in over 95% of the cases, you go in the operating room knowing precisely what needs to be done to the patient, particularly as far as valve repair is concerned. Because of my personal experience with transesophageal echo, since I was the surgeon that introduced this in the operating room back in 1985, I'm more comfortable with transesophageal echocardiography to do all valve repair. CT scanners and experts in MRI say, we can give you more information than echo. They can give the quality of tissue, which echo frequently fails. Aortic valve repair is an excellent operation in patients who have an ascending aortic aneurysm and secondary dilatation of the sinus to blood junction. Simple operation. All I have to know is anatomy and how the aortic valve functions. And by simple adjustment, the sinus to blood junction, we can fix the problem. The more common, however, the most common aortic valve repair is in this patient here, particularly in those that have a genetic syndrome associated with the aortic root aneurysm, which approximately 1 in every 500 individuals has that. The first one doesn't require much skill, just a good sonographer to tell you the cusps are normal. The sinus to blood junction is much larger than the aortic annulus, more than 20%. You go there, you don't put a graft of any size or so at random. You divide in 3/3 according to the size of the cusps. A bigger cusp requires a longer intercommissural distance. And if this doesn't allow them to co-opt, plicate the cusp. Very durable operation. You solve the problem of aortic insufficiency permanently. Simple, highly reproducible. This is more complicated, particularly if they are associated with genetic syndromes, because we learned over the year that a simpler operation, such as trying to copy nature by remodeling the aortic root, is not very durable, because you leave underneath tissue that is genetically abnormal and eventually dilate as well. Just like the mitral valve dilates in this patient, so does the intervallar fibrous body. Reimplantation had shown to be more durable in these patients with genetic syndrome. But don't throw away that operation. This is a great operation for older patients who have only ascending aorta and sinus dilatation or aortic dissection in the older patient. Our latest publication is in a subgroup with a genetic syndrome, supposed to be the worst ones for aortic valve sparing, and yet we just published in JACC in September this year. There is no operation in Marfans that provide this kind of survival, 87% at 20 years. Aortic valve sparing does, just like a mitral valve repair in patients with floppy mitral valves. Unfortunately, this operation is durable, but not infallible. But then if you include the reoperation, it's still over 80% are free from death or reoperation at 18, 20 years. Unfortunately, patients with genetic syndrome have one more disease that probably is independent from the genetic syndrome that caused the aneurysm, is the aortic dissection. Why some dissected, others do not, it remains undetermined, but the fact is, aortic valve sparing or Bental does not prevent them from dissecting later on, suggesting that these patients will require some more attention, try to discover what's causing that, likely genetically linked as well. Remodeling is a bad operation for Marfan syndrome and took 15 years for the space between the supraanal repair and the intervallar fibrous body to dilate and fail, literally every single one of them. So you don't want an operation that lasts only 15, 20 years. You want an operation that continues beyond 15, 20 years. If you match our patient to the population of Ontario, surgical ones do not do very well. But if you eliminate aortic dissection, the survivorship is identical. More importantly, and this is not comparable, it's a retrospective comparison. If you take Dr. Gott's bento from Hopkins and plot against valve sparing, at 10 years at Hopkins, the mortality was 19%. At 15 years, the mortality was 24%. Coincidentally, the clinical profile for our patients are identical. Same age, same proportion of dissection. With valve sparing, the mortality at 10 years is 4%. And the 4% was entirely due to aortic dissections. At 15 years, mortality was 7%. One bad lung, severe COPD, and the remaining aortic dissections. The more common aortic valve sparing is not for the aortic root aneurysm. It's for patients with bicuspid aortic valve, because 1 to 2% of the human beings have that. And a third of them become incompetent before they are 50. Here, we learned that they become incompetent because the aortic cannulus dilates. Again, it's a genetic syndrome. It is aortoanulocutasia. I'm not saying every bicuspid aortic valve is associated with annular aortic ectasia, but those that develop aortic insufficiency, most of them is. So cusp repair, subcamuscular placation is a bad palliation. One of my former fellows showed that in his latest publication, Dr. Alcuri from Brussels, showed that if you do a reimplantation in these patients with the aortic cannulus more than 26 millimeters in diameter, no failures up to 6 years, 7 years. If you do cusp repair, 20% reoperation. And more importantly, no aortic insufficiency up to 7, 8 years. A third develop aortic insufficiency if you do cusp repair. Indicating again the incompetent bicuspid aortic valve should have reimplantation to stabilize the aortic annulus. This is the end of good news about valve repair. That's the only two subgroups we do very well. If you add a 40 material to the cusp, it's a 7 to 10 year solution. So aortic valve replacement is the real world. Nothing has changed during my career. The choices that I entered practice in 1978 is still present today. You still have to choose mechanical, tissue, or two biological valves. After 37 years in practice and following every patient I have ever operated on, I learned that what determined the outcome in choice of valves, the patient lifestyle, the patient understanding of the aortic valve disease, the pathology in the aortic valve, and finally the age, of course. It's up to you to be able to take these 4 variables and advise a patient to the best possible type of valve. We should not throw away mechanical valves the way we have. I think it's a mistake. And we are doing more and more, collecting dust in the shelves. Mechanical valve for the right patient is a lifelong solution by the vast majority, not all. Does the type of valve affect survival? Well, we surgeons are very bad in randomization. Now, whole history of cardiac surgery, there have been only 3 randomized trials on the type of valve. 35 I collected retrospective study. We're very good in retrospective study. Very poor scientists in randomizing things. In VA, as you know, in the VA study, mechanical valve was associated with a 13% reduction in mortality at 15 years, almost 1% per year. Average age, the veteran, male veteran, 55 years. So to a 55-year-old, in this randomized trial, mechanical valve came ahead. In Edinburgh, they've literally randomized some 600 patients, but they lump together mitral and aortic in triple valve. I don't think is a reasonable randomization. It showed that if you put all together mitral, aortic, or double valve, 20 years later, made no difference. They tried to break it down by type of valve, but the sample size is too small to make a meaningful difference in log rank. In Naples, Italy, they randomized very older patients, 74-year-old. That's too old to randomize to anything. A 74 should have a porcine valve and go home. Don't think about, even in fibrillation, put a tissue valve. But they show no difference as well in these older patients. How about the retrospective studies? Oh, it depends where it came from. If you come from an institution like the Mayo Clinic, where the patients are highly differentiated, Mayo Clinic don't have many indigents. They don't have many foreigners who don't speak the language. Of course, mechanical valve is far better than tissue valve. If it comes from New York City, from Dave Adams, or New York States, tissue valve is better. Because half of them don't speak the language. How can you give Coumadin to someone who doesn't know to spell I and R? That's why the 4 variables I told you are very important. It's up to you to advise the patient to have a tissue or a mechanical valve. And never tell the patient that the tissue valve is going to be forever or mechanical valve is forever. Nothing is forever. Life is a fatal disorder. We all die. Mechanical valves, if you are in practice as long as I have, I'm seeing an increasing number of mechanical valves stenotic due to pendants. It's a foreign material in the heart. And most of us, you try to eliminate the foreign material by growing pendants. Not all, but many. But tissue valve not a solution either. Tissue valve, if the patient lives long enough, regardless the age, they fail. They fail for nothing else, from mechanical fatigue. The tissue cannot be bending forever. No tissue bends forever without regeneration. Unfortunately, we surgeons forgot this. Look what happened to the number of mechanical valves in the United States. It's shrinking down to 16%. And the age is going up, but the difference in age alone doesn't explain the number of tissue valve, because 2/3 of the people under 50 in the United States today are getting tissue valve. A lot of reoperation or TAVI in the future. Tissue valve have limitations. They are not as hemodynamic as good as mechanical valves, but the effective orifice is smaller. Tissue selection, if it's a porcine valve, plays a major role. I learned personally that most pigs have a very large muscle bar. You lose 1/3 of the orifice. By selecting, and the companies don't like to do that because it's very expensive. In every 100 hearts, you take 2 or 3 valves only. That's expensive for a company to make a pig valve. Well, removing the stent makes it more effective as well. And I thought back in 1985, why don't I do that? And we're going to eliminate the problem of the poor hemodynamics in tissue valve. In 1985 was a good idea, but I'll show to you that it failed in durability. In pericardial valve, it's a function of design. Pericardial was meant to be a leaflet. Therefore, the durability is linked to the design. The engineer's ability to make a sheet of tissue that can open and close so many times with minimal fatigue, because it is a foreign material. And there are different designs. The happiest, the luckiest design is this one here. And I'll tell you why in a minute. This one is a better design for hemodynamics, because it wraps around the stent. It's going to open 20-30% more. As a consequence, the effective orifice of these valves, size by size, it is 20-30% better than a Magna. Pericardial valves are better than porcine valves because they are designed to be more effective. How about durability, though? Well, durability is limited because the leaflet tears or become calcified, or both. The stent design plays a major role on durability. Unfortunately, negative way. Back 20 years ago, I thought this is going to solve the problem of aortic valve replacement based on my experience with the stentless homograft. Well, 12 years later, we stopped using Toronto valve altogether because Hancock, an identical valve to Toronto, but with stent, was a whole much better in durability. How about the Freestyle? Same thing. Not as durable as Hancock. At 15 years, Freestyle has a 75% freedom for same age group, 68. Hancock, 88. Bad thing to do. Stentless valves are not more durable than the stented valve. They are better hemodynamically, but you shorten the lifespan of the valve. Cusp design. Well, you better be careful with cusp design. You cannot change the cusp design on things created by God or nature, like a porcine valve, but you can in pericardial. Mitral flow is an excellent design hemodynamically because when you open like a cylinder. 30% better orifice than equal size magna. However, remember, when a mitral flow opens, it moves 45 degrees. When a magna opens, only 30 degrees, 50% less. We forget history. We don't read old papers. Daniel Lawson is a personal friend of mine, trustworthy. He's an honest surgeon with passion what he does. He published the mitral flow back 20 years ago. Look at the durability. His conclusion is very gentle. The pericardial valve has excellent hemodynamic feature, but lousy durability. Not all pericardial valves are the same. And until more data become available, the only durable pericardial valve is the perimount. There is data on that. The other ones have no data. You can try if you like. But you expose your patient to the risk of a bad valve. Nature of the tissue is very important. Is porcine better than pericardial? Well, Gluckman and Bodner published this paper in 1995, became a classic that everybody uses as a reference. This is the average durability of some 6,000 porcine valve. Hancock and Carpentier Edwards original. No Hancock 2, no Mosaic, no Epic, no newer generation. And here's the perimount. Better. Well, times have changed. 20 years changed a lot of things. From Tour France, I know this group as well, that's why I'm picking as a reference. They examined the result of long-term durability of Carpentier Edwards perimount with echo. Not clinical judgment, echo. In Toronto, we had done the same for the Hancock. Hancock 2. Survival, no different. Same age group. They're a bit older here, so the survival is a bit worse, but no difference, really. However, there is no difference in durability either. Perimount is as equally durable as the Hancock 2 valve, except for patients between 60 and 70. And I don't know if this is a fluke, because a single, only 2 series, or if this is real. The rest, under 60, no difference. Over 70, no difference. By echo, not reoperation. Pericardial valves are not more durable than porcine valves. Not the current existing ones. They are better hemodynamically. Calcification remains the problem with tissue valves. The phospholipids in the surface attract calcium and phosphorus. Free aldehyde, the glutaraldehyde, causes calcium. And on the past decade, we discovered they are antigenic as well. The porcine valves are antigenic. That's why it fails in young people. There is something in the surface, the porcine valve, called the alpha-gal. I don't know how many of you remember the blood groups of human beings, the ABO. If you take a look at that radical, those of us who have group A, we have galactose and fructose in that radical on the end. The group A is alpha-gal, just like the pigs. Well, guess what? At least for Hancock 2 valve, group A patients have a more durable Hancock than O or A and B. Likely because it's not as antigenic. It doesn't recognize as antigenic. We are trying to expand this to all tissue valves to see if we can find the same findings. But this is data. That's 30 years data that group A patients have a porcine valve that lasts longer. Doesn't last forever because of the mechanical fatigue. Porcine valves are more durable in patient group A than other blood groups. Likely because of antigenicity. Unfortunately, we cannot change the mechanical stresses. So higher the mechanical stress, hypertensive patients, mitral position won't be as durable. Another biological factor, such as PENOS, is going to affect durability as well. Durability of bioprosthetic aortic valve is highly dependent on patient age. I would like to submit to you that patients, younger patients, will benefit from a porcine if they are blood group A. The general belief that pericardial valves are more durable than porcine is erroneous, not the current porcine in pericardial valves. Not all porcine or pericardial valves are equal, so you have to know the brand, the manufacturer, and its history. Porcine valves are more durable in patient group A than other blood groups, particularly the younger patients. Homograph came down to is a nice device to implant. And I think if a patient has an abscess or a badly destroyed aortic root, there is no device better than this to put it in. As an isolated valve replacement, pericardial and porcine valves are more durable for any age. Don't throw away this operation. It's very sad that number of ROS at the STS just about disappeared. It's not as bad as we thought. We learn more about this. We learn a lot about the ROS. Actually, in my hands in the past 35 years, it's the only aortic valve replacement that restores lifespan to normal. Mind you, my patients are very young. I don't do ROS in 60-year-old. I do in 16 to 40. And that age group survival is identical to the population of Ontario. In our hands, doesn't matter if you do subcoronary, aortic root replacement, or aortic inclusion. What it matters is that the patient be young, particularly women. Major difference after 30 years. The lesion be aortic stenosis, not aortic insufficiency. Because in North America, aortic insufficiency in a 20 or 30-year-old is bicuspid aortic valve. And they come with a genetic syndrome of annular aortic ectasia. Bad for those patients. Actually, based on our experience, we're able to put a number. If it's a mixed lesion, or even if it's stenotic, but the end is too large, be aware of those patients. You might lose the autograft. And unfortunately, the bottom line is, if they have no evidence of connective tissue disorder, no mitral valve prolapse, no billowing mitral valve, which is an evidence of connective tissue disorder, the pulmonary autograft lasts your lifetime. At least in my hands, 30 years now. I cannot finish aortic valve without telling what's happening to TAVI, and Germany is always ahead of us because of reimbursement largely. But look what happened in Gary trial in 2014. The number of aortic valve replacement is stable in Germany, 1 in 3 now is TAVI. This is the things to come in our practice. You're not going to run away from this. Doesn't matter if you make a tiny incision, big incision. It's the cardiopulmonary bypass the evil. I'm going to finish to say a few words on mitral valve. Mitral valve, most of them can be repaired because luckily, unlike aortic valve, that most are stenotic, calcific. Mitral valve, most of them are floppy. The single most important thing is to know the anatomy of the mitral valve before the repair. Mitral valve seen from the ventricle is anchored by 2 papillary muscles. So mitral valve has what we call the mid-mitral line. 95% of the disease in the mitral valve is here. Floppy or ischemic is here. It's always the medial half because of anatomy. Luckily, the most common disease, 9 in 10 mitral valve disease in North America, is due to prolapse. They are 100% repairable. You don't repair them because you don't want to repair them, because it's too much work to repair in some of them. But they are always repairable, always. And I think it is worthwhile learning and trying. Carpentier established the foundations of repair, and you have to know them. They're all very valid. However, over the past 20 years, we shift entirely from resecting to preserving leaflets with Gore-Tex. We started a single Gore-Tex. We went to multiple Gore-Tex, like interdependent, all loop on each other. We resect only if the posterior leaflet is as tall as the anterior because of SAM. Particularly if you do asymptomatic patients, you don't want to have severe SAM in the end. So you detach the posterior leaflet, shorten the height, and put Gore-Tex everywhere. The most comprehensive paper ever published is ours. Most comprehensive because we have annual echo in every patient. So you're not talking about freedom from reoperation. Cardiologists don't send you freedom from recurrent, moderate regurgitation. The echo shows that. In summary, 51% were alive at 20 years and free from reoperation. Reoperation really only 6% of the patients. You cannot change the non-cardiac deaths. Everybody's going to die one day. Most of them are cardiac. And largely because we operated too late. This was a major emphasis to operate in asymptomatic mitral regurgitation if you can put them up there. In other words, repair the valve. During a 26 years experience, 37 patients only developed severe, but 61 developed moderate. So you don't cure the disease. The underlying process of degeneration goes on. However, 20 years later, 90% were free from mitral regurgitation. Interesting, aortic valve repair for degenerative disease is the same. It's almost like this is the limit that we can accomplish with valve repair, because eventually the genes win and the process goes on. I don't want to bore you, I'm running out of time for predictors, but isolated anterior leaflet prolapse always emerges as a predictor of failure. We have a paper coming up showing this is abolished if you use a bunch of Gore-Tex. In other words, if A2 is prolapsing, don't put 2 Gore-Tex, put 8 or 10. You start where the normal chorda is and extend it until next normal chorda by going in loops, in and out. Papillary muscle, free margin, papillary muscle, free margin, interdependent Gore-Tex. If we do that, anterior leaflet no longer is a predictor of failure. I always thought patients have severe MR for this two entities should have mitral valve replacement with preservation of the NH mitral valve. We even introduced an operation that was inspired by Bob Levine's experimental work on severance secondary chorda tendina. You improve somewhat, but 20% is to develop recurrent MR. I'm glad to see that the two randomized trial for moderate ischemic MR and severe ischemic MR prove what I have been doing for 35 years. It makes no difference if you replace or if you repair. I would like to submit to you, replacement is better if you preserve the NH mitral valve. Particularly if the ventricle is a bag, ejection fraction below 30–40%. And do annuloplasty in moderate MR makes no difference either. Irving Krohn published the most important paper as a spin-off of the two randomized trials. They fail because the only predictor in those trials were a basal aneurysm or dyskinetic segment. You can't make scar contract or hold the mitral valve without remodeling. This is my experience, identical to the Italians, that showed that if you compare repair to replacement, they do better with replacement when you exercise than for 6 minutes. They can walk longer distance, even have ejection fraction below 40%. Endocarditis is a problem. We try to repair desperate every time. And when this came to be, I jumped in this bandwagon. I thought, hallelujah, now we solved the problem. And every time you become too enthusiastic, you pay the price. It's all falling apart, unfortunately. It hasn't on the right side of the heart for some reason, but it has in aortic and mitral leaflets. The core matrix degenerates before new tissue can grow into it. But our pathologic specimen show it grows. Part of it is replaced, but large segments fall apart before it grows. Finally, Dave Adams and Dreyfus in Europe, I think, pushed the envelope too far for this. Dave Adams believed 70% of mitral valve repair done in New York goes home. 70%, most asymptomatic MR, mostly, 70% asymptomatic. Go home with a tricuspid ring as well. And he gives justification why. And he says that 5 years later, those who do not have the ring, 12% develop moderate tricuspid regurgitation. When you go home next week, take a look at all the echo reports in your hospital. See how many have moderate TR. After some beer, too much water, take a look at the TR. We don't know what moderate TR means, particularly after open heart surgery. And the patient have large annulus, more than 40 millimeters. Be aware of those. They have an advanced connective tissue disorder, and the MR is not due to dilatation of the annulus. It's due to prolapse. You're going to have to put a bunch of Gore-Tex, not a band only. I started by saying the two most important days in life are the day you're born and the day you find out why you're born. So my father, when I finished medical school, gave me a nice Rolex, which I have today, and said, it may never develop in your mind that your education is completed and you know everything, because we don't. Thank you.